that pituitary is by far the most important as far as the endocrine glands are concerned, because it is regulating the entire system. So when we talk about pituitary physiology, we are pretty much talking about the growth hormone physiology, we are talking about the thyroid physiology, the adrenal physiology, and the AVP physiology. So pituitary, of course, is very important. But what is more important than pituitary is the hypothalamus, because hypothalamus is the ultimate controller of pituitary. So when we talk about hypothalamic control, Dr. Manoj, what is the difference in terms of different hormones which are being controlled by the hypothalamus, the level of control, the type of control which happens from hypothalamus with the pituitary?
In relation to pituitary, there is always stimulatory control to the all hormone, rather than the prolactin, which is the inhibitory control, which has the inhibitory control.
So you're saying that all the hormones pretty much are under a stimulatory control, except for prolactin, which is under an inhibitory control. So why do you think there's a difference in that regard? Why is prolactin unique in that perspective?
Because all other hormones should be chronically secreted by the body. So it should be positively, the association should be positive. And in terms of the prolactin, it is only required while the lactation or like in the postpartum period.
So in the evolutionary perspective, prolactin is only one which is required on a timed perspective. That is why you want to suppress it. Rest all hormone you need for a daily purpose. You need ACTH, you need AVP, you need LH, FSH to a certain extent. So that's why you have got a stimulatory pathway in that perspective. But there are also inhibitory signals of other hormones as well. It's not just that you have got just the inhibitory signal for the prolactin. What do you know about the other inhibitory signals for other hormones?
Like somatostatin.
So somatostatin is pretty much inhibiting everything. Somatostatin is inhibiting TSH, it is inhibiting growth hormone, it is inhibiting ACTH. So that's why somatostatin receptor analogs are used to treat a lot of excess conditions like growth hormone excess, like thyrotoxicosis, which is TSH dependent, like even Cushing's disease, which is recurring. So this is somatostatin is one arm. Anything else? Do you think of inhibitory signals?
Feedback inhibition from there.
That is different. So from the hypothalamus. So dopamine coming from neurons is inhibiting prolactin. It is also inhibiting, and that also becomes important. So what we are talking about, what Manoj was trying to say, is the predominant tone. We are not saying that there is no inhibitory signal coming, somatostatin is coming, which is inhibiting the growth hormone, but the predominant signal is GHRH. Somatostatin is responsible for some pulsatility. So when you want it to be high, so it's like a fine tuning. When you are controlling, you want something to go up. You also want something to not allow to go up too much. Therein the somatostatin will come into the picture in that perspective. So this is an important aspect to remember. Now within the pituitary, we of course know that there is anterior and posterior pituitary. So Vibha, what are the major differences in terms of manifestations of anterior and posterior pituitary?
So manifestation, like if there is an anterior pituitary, the level of the prolactin.
So generally speaking, what you're trying to say is that in anterior pituitary and posterior pituitary are two distinct components. They have got different origin. One is neural and one is glandular. The other thing is that their blood supply is different. The nature of their overall process, how much radiosensitivity they have, are different. So which part is more radiosensitive, anterior or posterior? So anterior is more radiosensitive. Anterior is more sensitive for vascular damage. So when you talk about ischemic insults like Sheehan syndrome, mainly the anterior pituitary is affected. And the other big thing is that posterior pituitary is mainly producing two hormones, AVP and oxytocin. So oxytocin, you will not really know the clinical features in that regard, but AVP is actually not being produced by the posterior pituitary. It is produced by the neurons which are there from the supraoptic paraventricular nuclei, which travel the whole process, and which we'll discuss subsequently, that 5% of them terminate in the median eminence. And that's why even if your complete pituitary is gone, you will have enough vasopressin which is produced by those neurons that you will not develop diabetes insipidus. So when we talk about pituitary problems, we are largely talking about anterior pituitary. When we talk about posterior pituitary problems, these are actually problems above pituitary. There are problems which are happening at the level of pituitary stalk. There are problems which are happening at the level of hypothalamus. Therefore, the presence of DI. So, Nupur, in a child who has got diabetes insipidus with anterior pituitary hormone deficiency, do you think that lesion is at the level of the pituitary or it is above the pituitary? So this is a very important thing. So if your DI is there, if your prolactin level is high, you are not dealing with a pituitary lesion, you are dealing with a lesion which is above the pituitary. So these subtle things which we'll discuss. Of course, over the next 2 months or so, we'll be focusing about a lot of pituitary. So this is the basis about that we'll try to build up. So we all know that. So when we talk about endocrinology, we always talk about dual origin. If you look at various organs, they all have a dual origin. Pancreas, there is a pancreatic, which is endocrine and exocrine. They have a different origin. Often this is neural versus glandular. So again, that's there. Thyroid, you have also got different types. Follicular, parafollicular. Parafollicular are more like a neuroendocrine development. If you talk about adrenal, you have got cortex, which is glandular, and medulla, which is neural. So pituitary is also a similar structure. So pituitary has got two parts, anterior and posterior pituitary. So basically you have got the neurohypophysis, which is a neural structure, and adenohypophysis, which is a glandular structure. And this basically is the development which happens from the neuroectoderm and the oropharynx. So during the process, you have got the upward projection of the oropharynx, and you have got the downward projection of the neuroectoderm, and then they will try to meet with each other, and a lot of embryonic abnormalities can cause disorders, which we have discussed, which we'll be discussing much more in later on. So this is the rat case pouch, which is there, and this is the posterior pituitary. Around 3 to 5 weeks, they will emerge, then they will try to fuse with each other. What is the gap between the anterior and posterior pituitary called, and what, if it remains, what does it cause? So when the anterior and the posterior, so posterior is coming down and anterior is going up. So there might be a cavity sort of a thing which is there. So what do you call this cavity?
It is a rat case pouch.
So this is the same rat case pouch which becomes a cyst. So pouch, when it is enclosed from down, it becomes a cyst. So usually it will be resolved, but if it is there, it may cause a problem of pituitary dysfunction. So it will compress and you can have a multiple pituitary hormone deficiency. So rat case cyst is a very important differential in multiple pituitary hormone deficiency, which is congenital. How do you identify a rat case cyst on a CT?
I can tell about MRI.
On MRI, okay.
So MRI, there will be the fluid cystic lesion will be there,
which is between the anterior. Yes, and very importantly, if you give contrast, it will
enhance.
So membrane, the peripheries, the wall of it will enhance. That is the important parameter to go on to that. So this is what the rat case cyst will be. Now, of course, if you have a problem of anterior pituitary development, what will happen to posterior pituitary? Dhwani, suppose your anterior pituitary is not developing, what will the posterior pituitary do? So it will say, I am okay, this fellow is not coming. So it's like a relay race. He is not coming, so I'll stay there. So it becomes ectopic. So you have a hypoplastic anterior pituitary. You have got an ectopic posterior pituitary. And what about the stalk? So there is no descent. So how would there be a stalk? So no stalk. So you have hypoplastic anterior pituitary, absent pituitary stalk, ectopic posterior pituitary. This is known as the triad of pituitary stalk interruption syndrome. So this is PSIS. So this is basically a problem predominantly in the development of the anterior pituitary, and that's why the whole thing deranges from that regards. So now we have talked about the embryological basis. Now we have to understand the genetic basis. The genetic basis is very important because the level of the defect will decide the manifestations of that. So there are multiple levels. The first level is a very early embryogenic. So when your face is developing, your eyes are developing, your ear is developing, neck is developing, that is when the pituitary is forming. Second is once the pituitary has been formed, you have got the differentiation of the cells. And finally, you've got the mature gland. So from the early embryonic stage to the final gland development, there will be different types of transcription factors which will be acting. And they are sequential. So when I say sequential, it means that this will work till this point, then there is another factor which will come up, which will suppress the previous ones, and that's how the whole process goes off. If there's a derailment of one, the whole process may be derailed from that regards. So very early in terms of mesenchymal development, we have got things like WNT5, FGF8. What will happen if you have a problem in these genes, Dr. Vibha? BMP. So these are all hedgehog pathways. These are very early development. So you have no facial development. So they will present with lot of craniofacial abnormalities. So they will be, yeah, so holoprosencephaly, all those abnormalities will be there. From there, you have got a very, very important one which comes up, HESX1. So HESX1 defects has been associated with which defect?
This defect, it is associated with abnormal eyes.
So now we talked about the overall face development. Now we are talking about eye development. So septo-optic dysplasia. So septum pellucidum is defective. So midline structure. Optic nerve again going behind. Optic nerve hypoplasia is there. And you have a combination of that. So HESX1 is one of the causes of septo-optic dysplasia. It's not the only cause, but it is associated with that. So what we are seeing, these are much more severe, and this is basically becoming a more milder from that regard. So SOX3 again is there. Then further development, you have got LHX3 and 4. LHX3 and 4 will cause more of a spine. So now other thing is fine, but spine will be there. But any patient with multiple pituitary hormone deficiency, look at the eyes for roving nystagmus. How would you identify blindness in a newborn?
Tablet and torch.
Okay, yeah, and you can look at the blink response. So if the blink response is there, you will know that there's a blindness. So if you have a roving nystagmus, either rolling like this, think of a MPHD could be a possibility because of the optic nerve hypoplasia. Now, what is now known that it's not 100% genotype-phenotype correlation. Even HESX1 defects and severe defects may cause isolated deficiency also. Conditions which were known to cause isolated deficiency may cause MPHD also. But yes, there is some reasonable sense which happens in that regards. Now, after that, what has happened is that your anterior, so this will basically cause what? PSIS like picture. You got stalk interruption, you will have ectopic posterior pituitary, hypoplastic anterior pituitary, and the stalk is defective. Then you have got there is an anterior and posterior pituitary are there. The cells are there, but these cells need to differentiate. And there comes a very, very important gene, which comes into the picture here. So what does prop1 do?
It tells it prevents the work of HESX1.
So it stops. So very important thing to remember that many of these transcription factors will stop the work of previous. It's like a orchestrated pathway. It's like an orchestra. So this person will have this musical instrument starts working, they will stop and start. So as you said, prop1 will stop this. And then it will cause
work for the PAW1F1 to terminal growth of each.
Yes. So it is something like you have got, you are having a garden and somebody is giving manure and everything and all trees are growing. If you allow them to grow haphazardly, you will have chaos. So prop1 is like a gardener. It is stopping, okay, I don't want you to grow too tall, but I want you to mature. So now it is going to prune it and allow a good differential on that. So if you have a prop1 defect, besides having all the growth hormone, prolactin and cortisol and ACTH, all the deficiency, what is the anatomical effect which happens on the pituitary? If you don't have a pruning effect, what will happen? Pituitary may become large. So you may actually have an enlarged pituitary in the setting of a prop1. So prop1 defect may have a small pituitary, an enlarged pituitary, or again a small pituitary, depending upon when you are picking up. But just finding a pituitary mass on imaging in a child with multiple pituitary hormone deficiency, which is congenital, does not mean that this is a mass lesion. It may be prop1 defect to consider. And the reason is that prop1 is actually pruning. It is inhibiting. Like yesterday, we were discussing about the ZAC pathway and the HYMA pathway in terms of the beta cell development. So they are actually suppressing the beta cell. And if they are hyperactive in the fetal period and you stop it, suddenly they start grow too much. Same thing here, if prop1 is not working, everything else has HESX1 and everybody will be happy. They will keep on growing the pituitary without differentiating into the cells. So you will have a useless lump of pituitary which is there. The size may be big. So size will not really have an impact on that. So prop1 along with GATA2 and SF1, which is basically DAX1, will have DAX1, SF1 and NR5A1. So all of them will combine. And along with that, they will start using the POW1, F1. And then they will start controlling the different development of individual cells. So prop1 is a milestone in terms of pituitary development. Then you have got the development of growth hormone, prolactin. Then TSH, you know, there are two parts, alpha and beta. Alpha subunit is same for LH, FSH, HCG, and TSH. But beta, you will have different gene. And then you have TPIT. I discussed about TPIT, which is going to be responsible for the autoimmune. It's a major ACTH regulation. So we say isolated ACTH deficiency is extremely uncommon. But if you have a central ACTH deficiency, which is congenital, TPIT defect is likely in that regards. And POMC, of course, now we are talking about structure. So after that, you have got the pro-opiomelanocortin. Now everything is formed. Your pro-opiomelanocortin is not being formed. This will be a next level of defect. So they will regulate the ACTH defect. GATA2 will have a major effect on the TSH regulation and alpha subunit, and they will also control the LH-FSH. So this we'll discuss much more in detail when you talk about MPHD. You need to understand that different genes have a differential effect in terms of regulation of pituitary growth, and therefore the effects will be different. Now remember, NR5A1 or SF1 and DAX1 are always antagonistic. They have a role in adrenal steroidogenesis. They have a role in testicular steroidogenesis. They have a role in gonadal formation. They also have a role in the central gonadotropin regulation. So they will cause hypogonadotropic hypogonadism. So I think that we'll discuss much more in detail subsequently in that regards. So now we have discussed a lot about the structure. We have discussed a lot about the development. Now, how do these hormones mature and how do they progress? So Vibha, which hormones are useless for the fetus? Out of these hormones, which one are the useless ones for the fetus, which they do not need? So GH is of no role. TSH, they require, but they can live without it. But TSH is there for thyroid development. Prolactin, ACTH. Why?
This cortisol start forming.
So you need ACTH, especially in the 8 weeks of life. Why?
So because this the DHS being formed is converted to estriol, and it is the source.
If you do not have adrenal production of cortisol at 8 to 12 weeks in girls, they will have a huge problem.
They will
So they will virilize. So this is very, very important. So that temporary production of cortisol in 8 to 12 weeks is largely to inhibit ACTH to avoid the androgen production. That is very important. So generally adrenals are quiescent. The only work of adrenal in the fetal part is to act like a factory of DHEAs. It is producing the DHEAs and supplying it to the placenta, which converts, aromatizes it and converts it into estriol, which goes to the mother. So fetal adrenal is largely not working, but around 8 to 12 weeks, that is the time when your cortisol is increased to inhibit androgen production. And that is very, very important from that perspective. So ACTH, yes. LH and FSH. LH, FSH don't have any role.
Till the 12 weeks, the HCG.
So then after that, so LH is very important. So fetal testis. So what are the difference between fetal testis and fetal ovaries?
So the fetal ovaries are quiescent in the, but the fetal testes are active during the.
Fetal ovaries are quiescent in terms of hormone production. They are not sleeping because a lot of mitosis is happening. Their germ cells are maturing a lot. Fetal testis, the Leydig cells are hyperactive, but the Sertoli cells are sleeping. In females, fetal ovary, you have got the oocytes which are maturing. So by the time you are born, you are already a large number of oocytes have dead by that time. It's mainly already enteral follicle is already formed, but the estrogen production does not happen. So LH, FSH are important. AVP? So if you have somebody who has got DI, a child, what will happen to the, do you think anything will happen?
Yeah, in the fetal period, everything requires.
In which form of DI?
Nephrogenic.
Nephrogenic, not the other causes. So it's mainly in the nephrogenic DI. You may have polyhydramnios, polyuria, and all those things can happen. So now if we summarize, the most important of these would probably be ACTH will be of relevance. TSH would be of relevance because you want to develop the thyroid also. Here you want to develop the adrenal also, because adrenal development, if you have no ACTH, it will be atrophic. So you may not need it by that time, but as soon as the child is born, they may go into shock. LH, important for boys, because if your LHCG receptor is gone, you will have DSD. LH is gone, you will have micropenis. FSH may be from ovarian, but not too much. AVP, again, not too much. So most important we discuss is TSH, ACTH, and LH probably in that regards. But growth hormone is there by around 8 weeks. It probably doesn't do much work, but it is like the normal development which happens. ACTH also comes up at 8 weeks. And we told why it is there in 8 weeks, to produce that cortisol. Now, by 8 to 12 weeks, your cortisol is already appearing. So cortisol is one of the first actual end organ hormone which is being produced by regulation of pituitary. TSH happens by 12 weeks. So if you have a child who has got neonatal Graves' disease, in which, Nupur, if your mother has got high TSH receptor antibody, at what gestation will you start getting worried of fetal thyrotoxicosis? At what time?
The initial 3 to 4 weeks.
That will be the most important. So who's producing the thyroid hormone in the baby? The baby is producing. The antibody is coming from the mother, but the baby is producing. And the thyroid is not there till 15 weeks. 12 weeks, the TSH is not there. Thyroid hormone gets ready by 15 weeks. So before 15, 16 weeks, you will have no fetal thyrotoxicosis. So only after that, you start getting worried. And that is why the whole physiology becomes important. So thyroid, as I said, 20 weeks. So in the first trimester, nothing is going to happen. You can start monitoring. That's why we do the TRAB antibody around 20 weeks, 22 weeks. That is the time when you start getting worried. Okay, he may go into heart failure because of thyrotoxicosis, because now the thyroid is matured from that regards. Testosterone, 8 weeks, absolutely important. But we remember in the first 12 weeks, HCG will take over the work of LH. So if you have hypogonadotropic hypogonadism, you will not develop a hypospadia. You will develop micropenis, but there will be no hypospadia because HCG is taking care of the testosterone production in the first 12 weeks of life. Estrogen, as I said, the first enteral follicle appears at term. So you may have some estrogen production, but the estrogen levels are very high. Why?
Because in estrogen level are very high.
Female fetuses will have very high estrogen levels, yet they're not producing. Why?
Because it converts.
Converts from what? It comes from the mother. We all talk about transplacental passage. You know that there is a vaginal bleeding which may happen, gynecomastia may happen. So this is because of the maternal passage which is there. Now, prolactin is there for 24 weeks, but what work it does, nobody knows. It's not going to be very important. Now, the next question which comes is, Dhwani, which hormone become very important in the immediate postnatal period? So we talked about what is important in the antenatal. We said, okay, TSH, but you can live without it. ACTH, you can live without it. But which is the most important now? ACTH and? So when the child is coming out, when the child was in the fetus, temperature is taken care of, glucose is taken care of, sodium is taken care of. Here, you become cold suddenly. From an environment which was 38 degrees, it's like 20 degrees. And now it's like 2 degrees or something. Then your glucose is being used up. That is the second important thing. So the most important, of course, will be TRH will, of course, be very, very important because that is the surge which happens. CRH will also be very, very important because you need a cortisol surge to prevent hypoglycemia. But you have other changes as well. Is growth hormone important in this age group?
Yes.
Mainly for?
Because postnatal growth is predominantly.
But in the first day of life. A bit for hypoglycemia because growth hormone causes lipolysis. It is other things. So at birth, the growth hormone level increases. That is because of lack of somatostatin exposure. So that's why the growth hormone level increases. So using growth hormone alone, isolated growth hormone may not be a good marker of deficiency. In fact, the guidelines say that if you have hypoglycemia and the growth hormone is low also, you have to be very, very careful because often the response may be defective in that regards. But the IGF-1 does not go up. So what I'm trying to say again is that as in malnutrition, the growth hormone goes up, but the IGF-1 doesn't go up because growth hormone is being used for alternate sources. You can assume a fetus to be like a nutritionally deprived individual. He was getting a lot of something to already direct supply, which is cut. So growth hormone is high. I want to use everything. I want to use my fat store, but it will not cause growth in that regards. Of course, we all know about the TSH, the TRH surge, which happened. This is mainly for the cold response. This is a very important parameter. Prolactin also goes up. This is because of lack of inhibition. Again, nobody knows the role. So growth hormone and prolactin go up. They have marginal roles. CRF and other aspects, of course, you will have a huge flux which will happen and you will have a high increase in cortisol. What about gonadotrophins? What happens immediately after birth?
Increases.
So your levels are high, they dip, and then immediately they start rising. And then body says, okay, what is happening? I don't want it to increase more. And then it will suppress. And this is what is known as mini puberty. So why do you think mini puberty is curtailed in humans? Like, why is the puberty stopped in humans? Like, why does, like in animals, normally what you see is that they will be initial infancy and then they will have puberty and they will become mature. So why do you think human evolution has led to this process in which this puberty is curtailed? And this puberty is curtailed by, first of all,
this puberty is curtailed by
the higher hypothalamic centers which are inhibiting that. So why does the subconscious mind or the conscious mind wants to suppress puberty in a human?
body is not mature enough to handle.
So that animals also are there. What else is not good enough to Manoj?
Basically, human body wants, human child wants nurturing. So for the particular that reason, reproduction system should be not come into the picture.
So not nurture, there's so much to learn. Like animals don't have that much learning. So our children are learning for 12, 14 years. That's why if you talk about the concept of brahmacharya, then you say grahas, then vanapra. So this whole concept is the same. It is not that directly you can't jump from infancy to a grahas. You need to really learn a lot of things. A dog may not need to learn that many things. So that's why it doesn't matter. So this is an evolutionary advantage, which is very much there, which is there for the human child, that they have interrupted puberty so that they don't have to bother about reproduction. They've got 20 years for that, and then they can learn a lot of skills before they become, because parenting humans may be very, very difficult from that perspective. Another phenomena which is actually unique to humans is menopause. So why do you think menopause developed, Dhani? So most animals don't have menopause. Most other animals don't have menopause. Humans have menopause uniquely. Vibha?
So
This is common sense. This is not a scientific fact. So is it easy to rear a human child versus other animals? What is easier? Have you seen a calf getting birth, cow's child? Huh? Have anybody seen? So what do when they get up? As soon as they're born, they get up, they start feeding immediately. Does a human child do that? And the mother is also in a bad shape. So you need somebody else. So that somebody else will be grandparents, nana, nani, all those people will be there. So that is why you've got menopause. So from a species perspective, your role is finished once you have done reproduction. Theoretically, your work is gone. So the reason there is menopause is that you have got a senior person who is experienced to take care of the child, because human child is more fragile. So this is the evolutionary effect which we were discussing also in that perspective. So that is an important role. So same way, mini puberty is deferred and menopause is introduced. And these are two big changes which resulted in a overall much more maturity of human growth which happened subsequently.